Good morning, everyone. I'm definitely going to use my melatonin, but I like my melatonin with a bit of scotch or vodka. It works better, at least on the plane. I wanted to thank Claudia and the Leopoldina-Symposium for inviting me. It's a great pleasure to come to Berlin. And I wanted to take you through, let me just work this first. Okay, that's just my disclosures. I'm going to talk to you about early go-direct sedation, the sedation part of early go-direct sedation, and how it relates to pain, agitation, and delirium. And we've heard this morning again, including now sleep and mobilization. So I will take you through that. The clinical practice guidelines that was published in 2013 focused on light sedation and analgesia first as a principle in providing best management for prevention of pain, agitation, and delirium. Similarly, there was the previous guidelines, which was published in 2002, had the sedation use and its title. The new guidelines abolished that sedation title, and that's in line with reducing the focus on sedation. I'm going to show you that perhaps we need to maintain the focus of sedation, but in a different perspective. More recently, we saw yesterday the data from early go-directed mobilization in surgical intensive care patients, and also the more recent liberation from mechanical ventilation guidelines that was published in CHEST. And then we had our own study on early go-direct sedation versus standard care. So in the next 20 minutes or so, I'm going to take you through what we define as light sedation. I think a lot of us have struggled into what actually is light sedation. So I'm going to propose to you that we will be using an index that's called sedation index as a much better way of defining what light sedation is and what deep sedation is. I'm also going to show you data that the relationship between sedation index versus pain, agitation, delirium, and mobilization and its impact on important clinical outcomes like 6 months mortality and others. And then I'm going to show you some data that relates the early go-direct sedation to sedation index. This is the kind of like the temperature you will see in Berlin, and this is Berlin on a beautiful summer day. But you can also see that the temperature in February is quite low. And when I got the email from Claudia, I wondered why in February, but it's not too bad anyway. I think contrasting that with the temperature in Melbourne, you can see the difference in the scale, but also in the same day, within 30 minutes, you can see extreme weather would be very hot, and then in 30 minutes, it'll be very cold. Now, this is quite relevant to our sedation practice, where in the same patient, we would have a patient who is very agitated, and then 30 minutes later, after a bolus of propofol or midazolam, they're very sleepy. So we need to dissect the heat from the cold to actually be able to examine the effects of heat or deep sedation or cold or agitation on those patients. And you know, this is where I come from. Just last week, there was a lot of bushfires all around Canberra and in New South Wales. And a lot of people were on Coogee Beach and Bondi Beach, which is pretty famous. And I'm sure there'll be a lot of Germans in this crowd because they love the beach and they love the sun. So that's one of the best attractions. In contrast to what you would see in Berlin, this would be your attraction in Berlin. And there, the two kangaroos fleeing away from all the fires that were there in Canberra. These kangaroos, they're like some of our workers in ICU who are, you know, fleeing away from an agitated patients. So with all that in mind, keeping the heat and the cold and the deep and the light sedation. This is the way we look at at sedation categories. We define light sedation arbitrarily. There's just really no evidence which way to do it. There's convention that we say light sedation is -2 to +1, and deep sedation is -3 to -5. We don't have any validation for these categories. The validation for the RAS, for example, has been for the individual components of the RAS rather than the categories themselves. So keeping that in mind, I'm just going to show you what happens in a patient, and I'm sure you've all seen these patients in your ICU. This is a patient who's, just at 24 hours of their sedation scale. This is in a good ICU where the RAS has been measured every hour. And you can see that, from 8 a.m. to 8 p.m., you can see that the RAS scale goes all over the place between deep sedation in the early hours of the morning and then lightly sedated or agitated during the other day. So it would be very difficult to categorize the sedation intensity or the sedation level of this patient over the 24 hours. And if you take another patient who would follow similar things but on a different scale, you will see that this patient has deep sedation in different parts of the day, was slightly agitated, but definitely different sedation pattern. How do you differentiate between the two? Which one is better? We don't really know which one is better, which one is harmful. So I'm going to propose that we are going to divide the sedation, RAS sedation, into the deep sedation categories and the agitated categories. So the sedation category can be divided into sedation index, and the agitated part divided into the agitation index. And then in the middle, there is the best way where you need to be at the optimal 0 category. The sedation index itself is measured by adding up all the number of RAS in the deep sedation level, dividing that by the number of sedation assessments over the 24 hours, and that will give you a sedation index. So in effect, it gives you the weighted average of sedation over that 24 hours. So does it really matter? So I'm going to show you, for example, these two patients that I showed you before. They have two different sedation run over 24 hours, and if we look at only on their sedation part from under 0 to -5, you will find that the guy in the white line had a sedation index of 2.2. The guy in the yellow line has a sedation index of 0.95, which basically means that the guy who was in the white line had a significantly deeper sedation overall over the 24 hours. Now, does this matter? I'm going to show you through some of the data that we've recently done and looking into what's the impact of that. So we looked at a large number of patients in 42 intensive care units in Australia, New Zealand, Malaysia, and Singapore. And we included in this cohort patients who were ventilated for more than 24 hours. We excluded those patients who would not need deep sedation in the normal practice. So all these patients are really likely to be lightly sedated. They have no indication for deep sedation. We followed those patients up to 6 months for mortality and up to 28 days for delirium, sedation, and pain management. This is the study flow of those patients. We had a total of 710 patients, and we looked at those patients at 3 important time zones. We look at them early, which is before 48 hours, and there was 703 patients who fulfilled the time of being in ICU at 48 hours. We also looked at them at 5 days, and there was 674 patients who were still alive at 5 days. And then we looked at 7 days, when there were still 728 patients who were still alive at 7 days. So we conducted multiple statistical analyses at every single point, 48 hours as early, 5 days, and 7 days. So what we also done during the course of the study, we conducted regularly, every 4 hours, a RASS assessment of those patients. And we've done many thousands of RASS sedation assessments. And the mean sedation index in the first 24 hours was about 2.42. Those who were alive, the mean sedation index was 2.2. Those who did not survive, they had a mean index of 2.84. Just about under 40% of patients were mobilized, and again, just under 40% of patients had a CAM RCU that was positive for delirium. So we've done a lot of regular, consistent assessment of all those patients. So what I'm going to show you now is the relationship between the sedation index in the first 48 hours and 6 months mortality, time to extubation, and delirium. So if we look at them in terms of a Cox proportional hazard, it means that we put a line at 48 hours and then we examine the outcomes beyond 48 hours based on all the variables that are available at the 48 hours time point or before that. So what you will see here is the multivariable Cox proportional hazard model. And what you'll see on the left-hand side is the variables we tested for, and then you will see the hazard ratio, confidence intervals, and the p-values. And you will see that for values that are higher than 1, it means these patients suffered harm. And for the extubation, a value of less than 0.8 means that there was a delay in extubation. So because all patients start to be intubated, and then they get extubated, all patients start alive, then they die as they go. That's why the reverse of the hazard ratio. So you can see that the sedation index, amongst all other variables, has one of the strongest predictors of 180-day survival, time to extubation, and the delivery and the subsequent delirium. So any difference of one level of sedation index, 1 point difference, would increase the risk of death at 6 months by 29% and will increase the risk of you developing subsequent delirium by 25%. It will also reduce your chance of being extubated earlier by about 20%. The agitation index on the other side, while it did not impact survival or time to extubation, it definitely led to an increased delirium after 48 hours. One of the other things that were important at the 48 hours period, what you expected, Apache 2, which is the severity of index, also related to mortality and also related to time to extubation. Those patients who received dialysis in the first 48 hours also had a higher, like almost 47% increased risk of death at 6 months. So it all makes clinical sense. When we looked at the data in a different fashion, so what we did then is we divided the variables into those related to mobilization, pain, and delirium. There was no relationship between mobilization or pain or delirium before 48 hours and subsequent death at 6 months, extubation, or subsequent delirium. So it all goes back into the level of sedation index. We also divided the sedation index into 3 tertiles. So the very low tertile, the medium tertile, and the very high tertile. And there was like a dose-dependent effect between the sedation effect and survival. The lower your sedation index, or the deeper sedated you are, the higher and the more the risk of death at 6 months. Similarly, if you look at the sedation tertiles and time to extubation, you will also see that there was a significant increase in the median time to extubation amongst the 3 tertiles. Again, the lower your tertile, which means the lighter sedated you are, then the shorter your extubation time. We also looked at the tertiles in terms of sedation index and delirium. And again, although it's not as nice as you would see it, you could still see that there was a significant increase in the delirium in a dose-dependent fashion between the three segments of tertile. So we could ask ourselves, well, is there a linear relationship between the sedation index and each of these outcomes? So what we did a smoother curves for those ones, and what we found is that there was a kind of like a linear relationship where there is an increased risk of death as the sedation index becomes higher. So the higher your sedation depth, the more risk of death you would have. But there was like a cutoff point. I'm not sure whether this is working or not. Here it is. Yeah, there was a cutoff point around this point here where, you know, the risk of this probably just almost stable until about 1. So once you reach the sedation index of 1, there's suddenly a tip-off with increasing risk of mortality after that. When we looked at the sedation index and duration of mechanical ventilation, there was a clear linearity between the two relationships, where the higher the sedation index, the higher the lower your time to higher your time to extubation. When we looked at delirium, it also showed a similar way, where an increased sedation depth or increased sedation index led to a higher delirium. But at this point here, where we stopped looking at the delirium level at the -3, the relationship became a little bit more straight line. But that's probably just because of the measurements that we've done. So you could ask ourselves then, well, is this really all related to the things we've given them? So what we've done also is we've done an analysis to see, is there an interaction between important things in these patients and their sedation index and its effect on mortality. So we examined 4 subgroups that included, the patient age, their severity, whether they're less than 21 Apache, more than 21 Apache, their diagnostic codes, the country they were in, and amongst all these subgroups, we found no relationship between the sedation index and 100-day mortality that is influenced by any of these things. So there was no interaction between age, Apache, admission diagnosis, the type of surgery, sedative aids given, or the country the site was in on the relationship between sedation index and mortality. So I'm going to show you now the data when we've done data on 5 days and then data on 7 days. And what you will see here is that we looked at the level of delirium. You can see clearly here that the lower the sedation level, the lower the positivity of your delirium. So this may be the same patients, but as the lighter they become, the less delirium they will show. So when we looked at the delirium at 7 days and unadjusted for risk of death, we found that, like what other people found also, is that the patients who were delirious, they would have a higher risk of death than those who were not delirious. But this is the unadjusted data. When we look at it in terms of adjusted data, what we'll see here in the unadjusted data, that it's the sedation index that remained significant for death at 180 day, whether you measure it at 5 days or 7 days, and the mobilization episodes or the pain episodes or the delirium episodes essentially had no relevance to the 180-day mortality. It had absolutely no relationship with that. When you look at the things like patient age, whether they received dialysis or not, whether they received vasopressors or not, you could see what you would expect clinically, that those who received renal replacement therapy and those who received vasopressor had a higher risk of death within those 7 days or within the 5 days. Let me just take you back to the slides that I missed before, and that slides on the mobilization episodes. As we know that the sedation and mobilization, they probably go hand to hand. And that's what we found in our data here. We found that if you look at the sedation index, which is at the y-axis here, and the number of mobilization episodes, you can see that all the mobilization episodes, most of them have actually occurred below a sedation index of 2. So it's where that doesn't really relate to a RAS of -2, but that relates to a weighted average index of -2. So what essentially saying that to have patients mobilized, they have to be lightly sedated and they have to be awake to be mobilized. It's just a fact, you can't mobilize patients who are comatose. Similarly, when we looked at the mobilization in terms of mortality, in terms of unadjusted mortality, definitely those who were mobilized died less. But that's a selection of, in terms of severity, rather than unadjusted data. So this is the adjusted data I showed you before, and it clearly showed there is no impact of mobilization when it's adjusted for severity of illness, sedation index, and other variables. So when we look at the study that looked at the surgical patient in RC and early mobilization in those patients, clearly there was an improvement in their strength and RCU stay and a lot of other primary outcomes. But when you look at the rest of the data, there's actually increased hospital mortality in the patients who received the intervention. And there's also a higher but not significant mortality still at 3 months seen in the patients who received the intervention. So there's still more work that needs to be done in the mobilization field and the link to sedation. If we look at the liberation guidelines that was published by in CHEST more recently, their recommendation is pretty simple. Rehabilitation directed to early mobilization, use a ventilator liberation protocol, perform a cuff leak, and give steroids if there was cuff leak. But when you look at the evidence for that, every single one of those recommendations were made as a conditional recommendation because there was low quality of evidence. So there is still a substantial amount of research and work that we need to do to actually find what we actually need to do. This is our early data and data done in Germany where we looked at the early deep sedation within the first 48 hours. And what we found is that you look here, this is the Malaysian data, and it shows that the bars here is after 48 hours. So after 48 hours, most patients were actually in the zero target. The problem happens in the first 48 hours in the black bars where everybody is on the side, in the deep side. We saw the same in our study, and the data from Germany here also showed that this early deep sedation is very harmful in terms of extubation and mortality. For that reason, we developed the bundle of early go-directed sedation, which is a combination strategy that combines choice of sedatives and also titration of sedatives to a particular sedation target. So the bundle of early go-directed sedation specifically looked at delivering early interventions in terms of analgesia and minimal sedation, deliver effective analgesia, and we chose to use dexmedetomidine as an agent as a primary sedative for multiple reasons, including that dexmedetomidine gives you arousable sedation and improve your wakefulness earlier, and it's harder for bedside carer to actually make patients asleep or deeply sedated by using dexmedetomidine. We've also targeted light sedation frequently and titrated the sedatives continuously to a target level sedation of light sedation. The pilot study, which we published in Critical Care Medicine, showed that there was a significant reversal of the pattern of deep sedation in the first 48 hours. You can see that this is the study days here, up to 7 days. You can see that once you get to the first 3 days, then the difference actually disappears. There's actually no difference between the patients once you pass 72 hours. The majority, the bulk of the difference between sedation levels is actually in the first 48 hours. So we managed to reverse the pattern of deep sedation using the bundle of early go-direct sedation. Furthermore, what we found also is that using the early go-direct sedation increased the number of delirium-free days and also reduced the requirements and the use of physical restraints in the patients who were treated by the early go-direct sedation therapy. There was a significant reduction in deep sedation and also a significant increase in light sedation in those patients. The early go-direct sedation is currently the subject of a large multicenter multinational trial which aimed to recruit about 4,000 patients. We're currently about just under 2,800 patients, and the study should be finished by the end of this year or latest January 2018. The last thing I wanted to go through is that I was absolutely touched by what the patient was saying yesterday, and it reminded me of one of my own patients who was admitted to our intensive care unit with a significant pneumonia. She was 83. Her son flew from New York to stay on her side because she was very ill. And her son said, I want to have a whiteboard next to her bed. So he had a whiteboard next to her bed, and every morning at 9 o'clock, he will come and he will write to her on the board the tasks that she needed to do that day. What the day was, what's happening with the kids, what's the temperature outside, how she's doing, and all that stuff. At the same time, she said to me, she wrote a little thing, don't put me asleep, I want to stay awake. So she was kept awake, and eventually she got extubated. She left, went home, and then I invited her to speak at one of our sedation meetings, and she stood up exactly like the gentleman yesterday, and she said, I want to tell you something that probably nobody else told you. She said, every time I took a breath through that tube, it was like a burning flames going through my throat. And I said, wow, why could that be? Then I realized that it's actually the temperature of the humidifier, because as they breathe through the endotracheal tube, the hot air kept going in and out, and every time it goes in and out, it was for her like a burning flames going down her throat every time she breathed. Can you imagine how painful that would be? I definitely learned a lot from that experience, and I think being at this conference, I learned a lot of what we've achieved towards establishing goals that actually fit with what the patient needs. I think it's really a fresh air and really inspiring that we are now talking to the patient to design our ICUs, asking them what is it that we need to do and how we will do it. Having said that, while we done a lot of work to master all these things here, to give the patients all what we can, there's still a big disconnect between what we do now and what the patients want. And that disconnect is probably because we still have quite a significant gap in the infrastructure for the design, which we saw being addressed here nicely. We still have a workforce gap where we don't have enough of people that we want them. We don't have enough nurses. We don't have enough physios. And also, we still have a big knowledge gap where the evidence is still come from observational trials and small trials. So we are really in need of having to bridge these gaps. That's the only way that we can link what the patient wants and what we want as clinicians. So in summation, ladies and gentlemen, I wanted to suggest to you that sedation level is actually the driver of all good things. And rather than saying we don't want to give people sedation, we should say we want to give people the good level of sedation that's going to give them the calm, comfort, and the cooperation that would lead to better outcomes, including long-term mortality. Thank you very much. Happy to take some questions.
questions? I actually have a question. What do you think is the mechanism for the sedation index and mortality relationship?
Yeah, I think, you know, I think deep sedation has a lot of impact on multiple organs in the body. I think it definitely has a toxicity to the brain cells. We know that with the critical illness, the brain cells are already primed for injury. And I think we are probably, by the deep sedation, we are giving these patients a secondary injury, pretty much like the brain trauma patients where they get the primary injury at the scene, and then they get a secondary injury by hypotension, hypoxia, and all the other things. And I think deep sedation probably is the one thing that gives a secondary injury to an already primed neurological cells. Plus all the other things like, immune suppression, needs for significant more inotropes, immobility, all the things that we know it does.
Is the impact the same? And I know you adjust it for medication use, but whether their sedation index was like no medication versus some medication, like was there a separation out of people who had those low RAS scores that wasn't related to sedation?
Yeah, I think in our previous trials, we looked at the individual agents that were given. And what we found that although the different agents contribute to a higher sedation index, like midazolam, for example, was clearly linked to a higher sedation index, we could not take the next step and say the use of midazolam was linked to the mortality. The depth of sedation is what's causing the problem. It's not the use of midazolam, although midazolam itself caused deep sedation. So what I mean.
Thank you very much for this great presentation. I'm intrigued by your remark that deep sedation has a direct toxic effect on the brain, because in neurocritical care, sedation is often applied as a kind of neuroprotective effect. I was expecting that you would make a remark on sedation and the immune system, for example, which I think is an important aspect as well. But could you comment on that, on protective or detrimental effects of sedation with regard to direct effect on the brain?
Yeah. I think the data for the direct effect on the brain cells really come from animal studies done by Coleman in the UK, where they've actually looked at some rats who were given different sedatives, and they were basically, the rats became, they assist the rats for delirium and for other things, and they showed that different sedatives would make those rats definitely have a different neurological outcome in terms of cognition and memory. It's quite, I saw Coleman presenting this stuff in England, and it's quite fascinating to see that. I think in terms of in the human glial cells, I think it's still a speculated theory that it may be what it does. And I think the sedative agents, there are definitely multiplicities of them. So maybe there's a differential effects between the different sedatives and the, what happens to the brain. We don't know that yet. And that's why I think we do need some more larger studies and more studies specifically into biomarkers of brain injury and maybe, high fidelity neuroimaging to see what actually happens to those patients.